Well, hello, everybody. As you know, I'm Dr. Mark Morningstar here of the Scoliosis World podcast. Thank you for tuning in today. Um, the Scoliosis World podcast, of course, is powered by Back Genius. Back Genius is a company that has a network of doctors nationwide whose sole mission is to comprehensively, in the most comprehensive fashion possible, treat and manage all things scoliosis. All right, today I'm going to dive right in. It's a topic I haven't covered on any of my other previous podcasts before, and I, it I felt like um, I had a hint from out in the ether somewhere to kind of go over this topic today. Maybe it had something to do with my 8-year-old who had to have a baby tooth pulled today. So, in honor of her, the topic that I'm going to go through today is the idea of the association between various cranial or cranial facial asymmetries, orthodontic abnormalities, and idiopathic scoliosis. And I actually have a number of studies here that I can go through with you to kind of show you this. You don't hear very often about anybody within the conventional scoliosis community, and even for a lot of cases in the rehabilitation section of the scoliosis community, you don't really hear them talk much about this. And maybe that's because there really, as of yet, aren't that many good treatment options, or maybe it's because a lot of the necessary treatment options involve, advanced dental work, orthodontic work, something that is without, or I should say, something that's outside of the scope of practice for most, physicians and therapists who are treating patients with idiopathic scoliosis or for idiopathic scoliosis. So, but I thought I'd hit into some of these because it is quite interesting. And a lot of this research, um, is there's actually a lot of new research. When I first started learning about these kinds of associations, a lot of the literature that you would find these kinds of studies in was a lot of the older dental journals, meta research journals, and a lot of it was older from the 1970s, early 90s, mid to early 1980s. And I think over time, at least along the way, there's kind of this gap in some of this kind of research where a lot of the older studies, I feel like the knowledge in those studies just sort of kind of died on the vine, and people never really picked up that information and ran with it. And now I don't know if it's because of the advances in technology, imaging technology that we have, especially in the dental profession. But I feel like a lot of, in fact, all of the information that I'm about to go through today is only within the last 5 years. So it's all very new information, relatively speaking, and very germane to the idea of comprehensive scoliosis management. Because again, when you read some of these studies, the associations are very distinct, and it may well be that in somebody who has very, very advanced facial asymmetries, cranial asymmetries, bite malocclusions, things like that. Maybe some of those things are the rate limiting step in terms of how successful curve improvement might be doing whatever physical treatment that person is doing for scoliosis. So let me just dive right in here. First and foremost, this is a study from the journal Spinal Deformities in 2025, this year. Very new, just out here in July. Exploring the potential relationships between idiopathic scoliosis and various multifactorial diseases, a systematic review. Now, again, as you've heard me say on other previous podcast episodes, a systematic review is the single most powerful kind of a study design there is in biomedical research. So the conclusions that you can draw from in a scoping review or in a systematic review, typically are things that should be accepted by and large. And a systematic review, basically, from a very in a very detailed what's the word I'm trying to use here, in a very methodical way, looks at various studies based on a given topic and analyzes whether those studies meet the criteria for that topic, and what are their conclusions like? What are the strengths and weaknesses of all those studies? And then they include the better ones in the review. So, for example, in this particular review, they looked at under this idea of multifactorial diseases and idiopathic scoliosis. When they searched on, let's see, 6 different medical journal databases, they found 1,185 different citations, and 9 of those studies met the eligibility criteria for this review. Interestingly, significant associations in these 9 studies, significant associations were found between idiopathic scoliosis and these multifactorial disorders. Dental anomalies, which include asymmetrical canines, midline deviations, cross bites, overbites, multiple malocclusion, gingivitis, disto-occlusion, asymmetric molar occlusion, maxillary overjet, crowding, and reverse chewing cycles. They also found distinct associations to digestive issues. We already covered that in previous podcasts. We know that digestive problems are part and parcel to idiopathic scoliosis. Endocrine disruptions, hormone issues. We've already beat that, like a dead horse. Musculoskeletal imbalances. For example, the masseter, one of your primary chewing muscles, the difference in muscle volume of that muscle or the asymmetry of that muscle. And even oncological conditions, meaning cancer processes. So, interestingly, they conclude this study presents multifactorial and potential systemic nature of adolescent idiopathic scoliosis by revealing its association with other comorbid or concurrent medical conditions. These relationships indicate shared genetic, hormonal, neuromuscular, and immunological pathways. Scoliosis, I've been saying it forever, is not a spine problem. Idiopathic scoliosis results in a spinal curvature, but it's not a spinal problem. You have to look at it that way. If you don't look at it that way, you are only going to very irregularly be successful in treating the curve. And even when you fuse a curve, the results of that fusion don't last. Why? You never got rid of the reasons as to why that problem exists in the first place. And you'll hear me say that probably on every podcast I ever do. This is why companies like Back Genius are necessary. You have to treat scoliosis from a very comprehensive nature. You have to address the genetic, the hormonal, the neuromuscular, and the immunological pathways. You have to. Otherwise, you have no chance of providing or giving that patient the opportunity to have a lasting improvement in their spinal curvature, not just for the next 6 months or year or 2 years or 5 years, but for the next 50 years. You have to treat it comprehensively. So this is just one study. Again, systematic review, spinal deformities 2025. And I can even have Stephen put the study up here on the screen for you. All right. Next one, musculoskeletal science and practice. 2022. So again, only 3 years old. Is scoliosis related to mastication muscle asymmetry, meaning chewing muscles, and TMJ disorders? A cross-sectional study. So again, 29 patients, a little bit of a smaller study. However, what they did is that it was shown that TMJ symptoms were much higher in the idiopathic scoliosis group as compared to the control group or the non-scoliosis group. The volume of the chewing muscles was smaller in the idiopathic scoliosis group as compared to the non-scoliosis group. These results indicate that spinal curvatures affect anatomical, biomechanical, and kinesiological features of the masticatory system, meaning chewing. And individuals with idiopathic scoliosis may experience more chewing problems than asymptomatic or non-scoliosis individuals. Examining the musculoskeletal properties of the TMJ can provide information about the limitation of a TMJ in patients with idiopathic scoliosis. So, again, moral of the story, if you have idiopathic scoliosis, there may well be, as a practitioner, it behooves me to identify any hidden TMJ syndromes. For example, there are easy clinical checks where you can do where I can just have somebody open their jaw. And obviously, if my jaw is working symmetrically, my jaw should be opening smoothly straight up and down. However, if I have an issue with the TMJ on one side or the other, my temporal mandibular joint, as I open, I may start to notice clinically that the jaw deviates to one side as it opens. And if it does, then I can sort of deduce from that that the TMJ joint on one side might be stuck and the muscles on the other side might be weaker compared to this side. And so now again, nobody knows in these studies how that TMJ problem or that chewing asymmetry problem is associated with scoliosis. They just know that it is. The previous authors say that these are all common problems with scoliosis, meaning the spinal curvature. These authors are suggesting that the curvature is contributing to the TMJ. But the reality is we don't know that. They only identified an association. And I think that's an important distinction. For purposes of research, there is a distinct difference between causation and simple association. Okay. And I think that's very important to look at. So, for example, in a different clinical situation, we have people who have a lumbar spinal curvature or a lumbar scoliosis who also have a pelvis that's low on one side, which maybe gets interpreted as a short leg, probably really isn't a short leg, but it looks like that. So the hip is low on one side, and that's where the curve goes off. Well, you can make a case that the pelvis tilt and that hip being low could be contributing to that spinal curve. But the opposite can also be true. The curve can be causing that hip tilt, or the hip tilt is essentially an adaptive response to the spinal curvature. Those two often are associated. However, we don't always know which is which. And we've had many instances here in my office alone where both of those things can be true. For example, if you level out the pelvis tilt with a shoe wedge, for example, or a shoe insert, sometimes adding that shoe insert and raising the pelvis will correct that curve 5, 6, 8, 10 degrees in some cases. In other cases, raising that tilt up can make the curve worse. And then when that happens, we can infer that the tilt is a result or a response to the curve, not a contributing factor to the curve. So easy thing to kind of look at here. Now, present day, unfortunately, we don't have that same kind of a ability to test that in a clinical scenario. It's not like somebody can fix a TMJ problem in one day or overnight or even temporarily. It takes time. So nobody has really studied whether or not fixing some of these facial asymmetries also fixes the spinal curvature. We just know that they're associated. Moving on, next one here. This is also July of 2022. Spinal disorders and mastication, chewing. The potential relationship between adolescent idiopathic scoliosis and alterations of chewing patterns. Very interesting study. And again, none of this stuff is old. This included 40 total patients. 32 patients, and all essentially teenagers. 14 years old was the average age of the group. And they compared them to the similar group who did not have scoliosis. Chewing was measured in both groups. There was a significantly higher chance of chewing problems in the scoliosis patients compared to the control groups. The results of the study indicate that the presence of idiopathic scoliosis influences mastication or chewing, one of the main functions of the stomatognathous system. Well, they then call for a multidisciplinary approach for these patients may be relevant in providing the best treatment outcomes. What do you know? I've only been saying that for I don't know how many years, probably more than a decade now, at least. Scoliosis inherently is a multidisciplinary problem. As other studies have suggested, if scoliosis has a hormone component, it has a genetic component, it has a neurological component, and it has an immunological component, and it has a digestive component. I have 5 different systems that, conventionally speaking, require 5 different specialists: gastroenterology, immunology, neurology, um, endocrinology, and dentistry. These are easy to go for away, and then you could take 6 geneticist. So scoliosis literally requires all 6 of those fields of specialty to really deal with scoliosis in as robust and comprehensive as a management strategy as possible. You can't simply throw a brace on a child and expect their curve to stay better. You can't simply fuse a curve and expect it to stay better. You can't simply run them through a boot camp and expect their curve to stay better. It's just not going to happen. You have to treat it comprehensively. A lot of people are doing components of treatments that are very, very good in and of themselves. But if you don't complement those things and address the entire spectrum of why scoliosis exists in that particular individual, they're not going to stay better, and probably not even going to initially get better. They're going to fail treatment and assume that the treatment itself that they were participating in just doesn't work. And it's not that the treatment doesn't work or is bad. Like, take hard bracing, for example. Sometimes bracing among alternative providers like myself gets a bad rap for being ineffective. Some studies show that it's ineffective. Other studies show that it works very well if you wear it. I think in many cases, a brace fails because a child wasn't addressing the core underlying reasons when they could have been. And just adding basic complementary things to the mechanical or the physical side of the treatment approach would go a long way in making sure that the improvements and the stability gained from doing the physical treatment are much more likely to last on a long-term basis. So, last here, another study out of the Curious Journal. This is published in March of 2025. So again, very, very recent study. The relationship between orthodontic abnormalities and spinal deformities, a review of the literature. Now, again, they looked at all of the major biomedical research journal databases, meaning Google Scholar, Medline, Cochrane Library, PubMed, Science Direct. And basically what they found, they searched reverse chewing cycles, crossbite, scoliosis. And what they showed in here, let me find the main part here. Here we go. Studies have demonstrated a statistical correlation between adolescent idiopathic scoliosis and orthodontic anomalies such as overbite, overjet, and mandibular retrusion. Additionally, reverse chewing cycles, a characteristic of crossbite, have been found to be more prevalent in individuals with scoliosis, suggesting a possible link between dysfunctional chewing and spinal deformities. Considering the complex interplay between occlusion and posture, a multidisciplinary approach to the diagnosis and treatment is regarded as essential. Not do it if you wanna, essential. While orthodontic treatment effectively corrects malocclusion, evidence suggests that dental bracing may influence TMJ function and spinal alignment, especially in pediatric patients still subject to subsequent growth spurts. And then, of course, they always do the cautionary tale. Despite emerging data indicating the relationship, further research is required in order to confirm this. Yada, yada, yada. But the point is, key things to put out of there, fixing tooth alignment, jaw alignment, can improve scoliosis. And again, this was published in, let's see here. This was published out of South America. And again, whether you're in South America or you're in Italy or where was the other one at here? It doesn't show their associations, but so basically, no matter where you're at in the world, people who are really on the most cutting edge research as involved as it pertains to idiopathic scoliosis goes, they're all saying basically the same thing. Multidisciplinary approaches to scoliosis treatment are essential. That means I have to address the hormone component. I have to address the genetic component. I have to address the digestive component. I have to potentially address a dental component. And if I'm missing any of these things, my treating the curve, whether I'm doing scoliosis specific exercises, whether I'm doing a rigid brace, whether I'm wearing a scoliosis activity suit, whether I'm doing a boot camp, whether I'm wearing a spine core brace. I mean, no matter what I'm doing, if I'm not addressing all of these parameters, my physical treatment is far more likely to fail. Now, I don't know about you, but as a dad myself, I don't want my kid to participate in a treatment that is doomed to fail from the beginning because I'm not addressing all the factors of the problem. From the easy scenario or the easy analogy I always give to my patients, hey, look, if I want to build a house, I need a lot more tools than just a hammer to build a house. I need a whole lot of different kinds of tools that do all kinds of different things. Scoliosis is no different, folks. If I want to treat scoliosis effectively, and I want to treat the person who has scoliosis effectively, not just for the next year or two, but for the rest of their lives, I have to treat the entire condition. Multidisciplinary treatment is essential. Trying to make sure I say that 6 times on the podcast today so you guys remember that. Multidisciplinary treatment for scoliosis is essential. That is the take-home message, pure and away. You guys have any questions about anything, feel free to reach out. You can always email me directly, mmorningstar@backgenius.com. You can always, obviously, if you like what you see, please, please, please subscribe to Scoliosis World. You can hit the subscribe button on this video, and by all means, become a subscriber. I appreciate that. The more we spread the word, the better off everybody gets, because the only way to get conventional treatment to change is that enough parents demand it. So with that, I'm Dr. Mark Morningstar, Scoliosis World Podcast. Thank you for tuning in today, and I'll see you next time. Thank you.